Good morning or good afternoon, everyone, and welcome to AVAC's final webinar in our series focused on cervical cancer awareness. Today, our speakers include Dr. Samiya Mahmoud from the Association for Prevention of Septic Abortions in Bangladesh and Dr. Helen Kelly from WHO. Please put any questions you have in the Q&A or chat for our speakers to answer at the end of this session. Additionally, this session will be recorded and uploaded onto the AVAC website with PDF copies of slides. And with that, I turn things over to Samiya. Please find her bio in the chat.
Hello, everyone, and thank you, Alison, for giving me the floor to celebrate the Cervical Cancer Awareness Month, which was on January actually. So here I am, Dr. Samiya Mahmoud, currently working as a program manager to improve the sexual and reproductive health and rights services in urban areas. But before starting to work here, I had an opportunity to work with Mary Stopes Bangladesh as a project manager to lead the cervical cancer project. And during the project, I got several opportunities to work so many different group of peoples. So I worked with the general population in who represent the urban areas. I also work with some slum dwellers and also work with the female sex worker. So today I'm gonna share with you the cervical cancer and female sex workers experience and insights from Bangladesh. The sex worker as a key population, we see that the HIV and HPV prevalence rate is comparatively higher in the female sex worker group rather than the normal women group. So here we see that HIV prevalence rate among the sex worker at 2.5% compared to the general adult population is 0.7% only. And HIV incidence among the female sex worker was 8.6 times higher than the all women age 15 to 39. We also see that HPV prevalence rate among the sex worker is higher worldwide, around 40% of HPV type 16, which causes the cervical cancer, and the most common type of um, identified actually. It's HPV type 16. So from this slide, we see the sex workers are the heightened risk of both cervical cancer and HIV. Now, I'm going to share with you the sex workers country context, our Bangladesh country context. So around 100K to 200K sex workers are working in Bangladesh, and they work in a three different types, right? Like some of them are brothel based, some of them are hotel based, and some of them are street based. But the majority of the sex workers are from hotel or street-based. Sex workers in private is legal, and they are legal, and there are a legal system of brothels which are mentioned by the local monitored, which actually monitored by the local authorities, and about 14 official brothel complex housing where at least 4K sex workers are lived there. The brothel-based sex worker must pay a fee to the police and obtain a certificate from the magistrate to operate in the brothel. However, it is understood that bonded labor and exploitation are prevalent within the brothels, and sex workers often face barrier to accessing healthcare services. Now, I will share you the Bangladeshi context of cervical cancer. In 2020, we see over 8K women are diagnosed in cervical cancer, and almost 5K women died due to cervical cancer in Bangladesh in 2020. So cervical cancer is now the second most common cancer among the women in Bangladesh. To prevent the cervical cancer, Bangladesh government has committed to scale up national cervical cancer screening program. So government took three-tier program. In first, the primary prevention. For this primary prevention, government took health education, behavioral change communication, HPV vaccination, and this vaccination program now included into our EPI national program. And also promote the condom uses per partners. In secondary prevention purpose, government took two measures. The number one is via screening. Women who are at least the age of 30 to 60 should do via screening in every 5 years interval. And if they found positive, they took the immediate primary treatment by thermocoagulator or cryotherapy. So we see the via screening, it means visual inspection by acetic acid. And the tertiary prevention purpose, government take the initiative to early detection and treatment if invasive cancer are present there. And if the metastasis is done, then government took the palliative care initiative too. However, coverage of bias screening remained persistently low. Only 7.5% of women aged between 30 and 49 years age group had gone under cervical cancer screening program in their lifetime, according to our Health Bulletin 2019. Compounded by challenges, main reason are low retention of trained staff, poor linkage to onward care and treatment, and inconsistency of quality standards. Therefore, most of Bangladesh awarded cervical cancer screening and preventative treatment project, which is funded by GSK, GlaxoSmithKline, and it was the time duration was 2015 to 2018. So during this time period, Marist of Bangladesh do the via screening and cryotherapy treatment for precancerous lesions. So we do via screening in 3 different group of population. We did this in female sex workers, in urban slum dwellers who did not identify as a sex worker. And number 3 is women in other urban area who could be considered the representation of the general population in urban setup. After the screening, we see that sex workers had the highest positivity rate for precancerous lesion. They found 50% positive cases compared to 5% for women in non-slum urban areas. On the other hand, we also found that women in urban slum areas also had a high positivity rate, and it's about 31%. Because the polygamous practice of the slum dwellers' household husbands may be the link to heightened transmission rate of the sexually transmitted infection such as HPV. So we under this project we also do the via screening, and we give the one-stop service by cryotherapy services. So the cryotherapy is the freezes of the lesion and prevent the lesion to develop into cancer. So after receiving the cryotherapy treatment, according to WHO guideline for screening and treatment of cervical cancer precancerous lesions, state that women should observe a 4-week period of abstinence following cryotherapy to enable the cervix to heal and to reduce the risk of transmitting HIV and other sexual transmitted infection. As brothel-based sex workers are reliant on sex work for their income, MSB wanted to find out if following this guideline was feasible for them and learn more about the sex workers' experience with the screening and preventative treatment to improve the services to this population in future. So MSB undertook a qualitative research, interview 16 sex workers who had received the cryotherapy and 6 brothel leaders at the brothel in the Dhaka area from October to November 2018. Now, here we see the brothel leaders. The brothel leaders are the people who play an important role, such as there is a hierarchy in place and each brothel leader has a number of female sex workers working under them. And the leader was responsible to provide the guidance to the sex worker on so many things like how many clients will they deal per day, and whether she used the family planning methods or not, when she took the health services if needed. And the leader also took some percentage from their sex workers' income. So the brothel leader play a very important role to the brothel. Now, I'm going to share with you the sex workers' experience with the sexual and reproductive health services seeking behavior. They actually appreciated our services, but abstinence period is a big challenge for them. So the participants valued the screening program because definitely the service was free and they received the immediate treatment when they diagnosed as a VIA positive case, and they were treated respectfully by the provider. But some of them were said that the service was crowded, rushed, and they were fearful for the procedure. Post-treatment abstinence period was simply not feasible due to dependence on sex worker for day-to-day survival. But the interesting thing is no major adverse effects were reported by the participant in not following the abstinence guideline. Consistent condom use emerged as an ongoing challenge for many of the sex workers because condomless sex is often offered more charge for their work. Now, the experience with health-seeking services, they faced three major barriers. The first is discontinuation of the short-term family planning methods. The participants predominantly uses the oral contraceptive pill and the injection. But discontinuation rate is very high due to the side effect and other perceived health concern. Therefore, unintended pregnancy and abortion rate is very common and very common practice over there. Here we see that I mentioned MR. MR means the menstrual regulation. In our country context, instead of abortion, we said it menstrual regulation, and it is legal here, and government permit to do legally MR services up to 12 weeks from the first day of the last menstruation. But the female sex workers barriers accessing MR services due to discriminatory attitude of the healthcare provider and descriptions of incomplete or failed MR procedures suggested that sex workers may be restoring of the accessing unsafe services. And lastly, the accounts of brothel leaders and sex workers indicated that bonded sex workers are subject to extreme exploitation. The limited agency to negotiate the safe sexual practice and secure timely access to health services, making them particularly vulnerable to a range of SRH concern, including STI, unwanted pregnancy, and unsafe abortion. To improve the cervical cancer screening and preventative treatment services delivery for sex workers, our study recommendation for the implementers. So we divided into three major groups. Number one, awareness creation activities for the screening and prevention and treatment services. we have to clear measuring and provide clients with a strong understanding of what the procedure involves. And we also ensure gather involvement of men in screening activities. This could include awareness raising session to sensitize men on the importance of cervical cancer screening, as well as trailer to the counseling for men on the post-treatment guidelines. The another recommendation based on the counseling, we have to extend the length of the pre-treatment counseling to reduce the client's fear of the procedure and particular reassure the client on the use of the medical equipment. Extend the length of the post-treatment counseling to improve the understanding of the post-treatment guidelines with emphasis on HIV, STI prevention strategies, particularly in high HIV prevalence context. Conduct follow-up visit with the sex worker as well as their regular clients during the healing period to reinforce post-counseling measures around the abstinence and HIV, STI prevention. And lastly, the recommendation on ensure the accessibility of SRHR services by provide incentive to the sex workers and brothel leaders to cover their loss of sex worker income during their abstinence period. Consider the opportunities to adapt SRH programs and strategies to serve the sex worker and overcome the persistent barrier to service uses, such as a single provider outreach model to deliver the discrete one-to-one SRH services within or near brothel complexes, while establishing a network of sex worker-friendly providers for referrals of onward care. And integrate a component on service provision to sex workers into provider values, clarification, training to address the provider's stigma. And lastly, link with other agencies to ensure sex workers have access to a range of health, social support, and legal services. Before ending my session, I would like to share with you a story when I work in the brothel. I want to share with you a case story of Molly. Molly lived in a brothel of Tangal district and she is 32 years old and she worked as a sex worker for 14 years and she is a mother of one daughter. For last 4 years, she took oral contraceptive pill every single day and she took only the white medicine without any interruption and did not take any iron tablets. She was suffering from mild lower abdominal pain, excessive vaginal discharge, but no one could offer her proper medical assistance. During the awareness session conducted by Maristoff's cervical cancer program, she informed about cervical cancer and via screening. So she willingly came to our center and do the via screening. At that time, in the month of April 2017, She was when the team of Mary Stopes' headquarters went for a free via screening camp, Molly was found via positive, and the lesion was more than 75%. The lesion was so aggressive, cauliflower-like, and bleeds on touch. Then she was advised to refer to Dhaka Medical College to do the lip biopsy, which is needed for her further treatment. And her lip biopsy was done at Dhaka Medical College, which is the biggest tertiary government medical college in Bangladesh. And she received the treatment accordingly, and she is absolutely fine at that time. So this is all about my presentation today. If you have any more questions, please feel free to ask. For additional research, here I share 2 links. You can go there and for further queries. Thank you. Thank you all.
Thank you so much, Samiya, for such a wonderful presentation. I think that we've all learned a lot today about cervical cancer among sex workers and what the screening and treatment process looks like. And with this, I turn things over to Helen Kelly, who will talk about cervical cancer among women living with HIV.
Thank you very much, Alison, and thank you to you and the colleagues at AVAC for giving us the opportunity to speak on this topic today. I have prepared this presentation with colleagues at WHO, including Shona, Dalal and Maribel Monte. And the title of this talk, or the focus of this talk, is really to give an overview of control and prevention tools that we have for cervical cancer, specifically focused on women living with HIV. So many of you are probably familiar with this map of cervical cancer incidence globally. There in 2022, there were over 600,000 incident cases detected, the majority of these being in low middle income settings, and in particular in sub-Saharan Africa, as depicted there in the dark red in the map. There are 3 main reasons for the higher incidence in these settings. One is attributed to the disparities in access to screening, cervical cancer screening, and this review of screening programs globally found that 88% of women in high-income countries reported ever being screened, and this was compared to between 13 and 15% in low-middle-income settings. Similarly, for HPV vaccination coverage, we see these disparities in access to vaccination in the target population of girls, where almost 90% of girls in high-income countries have received a full course of HPV vaccine, compared to 40% in low-middle-income countries, although that is changing and increasing year on year. But added to that is the impact of HIV. And as we can see in the map on the lower right-hand side, the areas with high HIV prevalence are also the areas with high incidence of cervical cancer. And we do know that there is a link between cervical cancer and HIV. And it's been recently reviewed that women living with HIV have a 6-fold increased risk of cervical cancer. This is an important topic because the population of women living with HIV globally is large. And we do have the tools for prevention. So I'm going to talk a bit more about those in the rest of the lecture or talk. But just to understand a little bit better why women living with HIV may have a higher risk of cervical cancer, it's important to understand the natural history from HPV infection to cervical cancer. And women living with HIV have a higher risk of acquiring HPV, but similarly, there's this bidirectional relationship where HPV positive women also have a higher risk of acquiring HIV. And this is because both are acquired sexually and they share the similar risk factors for acquisition. Because women living with HIV have an associated immunosuppression, it becomes more challenging to clear those existing HPV infections. And therefore, women living with HIV tend to have multiple high-risk infections at any one time and have a broader range of high-risk infections. The associated immunosuppression means that these infections will persist, but also they can develop into low-grade and high-grade lesions, and ultimately, if not detected on screening, this can develop into cervical cancer. However, over the years, we have acquired more evidence that ART is beneficial in clearing HPV and also reducing the risk of low and high risk lesions over time. But it's really important that ART is started early and associated with sustained viral suppression and high CD4 count. So we talked in a previous seminar about the current tools we have to prevent cervical cancer, and these tools are implemented at different points of the pathway from HPV infection to cancer. So to prevent HPV infection, we have very highly effective HPV vaccines. At the point when HPV is acquired, we have screening strategies which include tests to detect HPV DNA, but also we have the more historical screening modalities, including visual inspection and cytology. And then once lesions are detected in screening, we have effective methods for treatment of pre-cancer, but also for cancer. When we consider women living with HIV, the role of ART is extremely important, antiretroviral therapy, and we have more evidence on its impact across the pathway from HPV infection to cancer. So some of the questions that I'll address in the next couple of slides is, with the advent and availability of antiretroviral therapy, women are attending HIV clinics routinely. So there's an opportunity to integrate or incorporate some of the screening and prevention tools for cervical cancer in these settings. But we also want to ask the question, what truly is the impact of antiretroviral therapy on HPV and related outcomes? In terms of screening and treatment, what the evidence is on the effectiveness of these approaches and how can it work in practice. And then from the point of view of HPV vaccination, is this safe in people living with HIV? Is it effective and is it cost effective? So we look a little bit more closely at some of those areas. So in terms of the association of ART on HPV and cervical cancer, up to recently, there's been some inconsistency about the beneficial impact of ART. But this meta-analysis was conducted where it found that in women taking ART effectively, had a lower risk of high-risk HPV infection. They had a lower risk of those infections developing into low-grade lesions, but also a greater probability of lesions regressing over time. And that was compared to women not on ART. But most importantly, women taking ART were at a lower risk of developing cervical cancer over time. Now, it's really important that within the studies that looked at the effect or the association of ART, that we found that the risk was lower if ART was initiated early in HIV infection, where the nadir CD4 count was higher, but also that women were taking ART over a longer period of time, were adherent and had sustained viral suppression and stable high CD4 count. So in fact, it was the history of immunosuppression that was an important predictor of women's risk of developing cervical lesions and cervical cancer over time. An important question we ought to consider is, I should mention that within many of these studies, many of them had enrolled women on historical or older guidelines for initiation of ART when CD4 count was a lot lower. And now that we have the newer guidelines were indicating initiation of ART at the point of HIV diagnosis before CD4 count decline, this may have a big impact on women with HIV, their risk of developing cervical precancer and cancer. And a really important question to address is, will the risk of cervical cancer in women living with HIV who started ART early in their HIV infection have a similar risk of cervical cancer as HIV negative women. We're not yet there with that data, but hopefully there will be some promising data on that in the future. So moving on to screening then, we have the three main modalities for screening listed there in the table: visual inspection, cervical cytology, and HPV DNA, which many of the current tests at the moment target up to 14 high-risk types. So I'm presenting here in this table a meta-analysis of the diagnostic accuracy of these different approaches in women living with HIV. And this was for the detection of cervical precancer or CIN2+. And what we can see here is that the proportion of women who test positive varies quite substantially depending on the test that's used. And as mentioned by Dr. Mahmoud earlier, visual inspection can often be quite difficult to implement in terms of the training and the quality of the examination itself. So this is why we see this quite broad range in terms of sensitivity and specificity for cervical precancer using VIA. Similarly, for cervical cytology, we found the same, and this may be because it's less likely to be used in settings where HIV prevalence is highest. On the contrary, for HPV DNA, we found more consistent results and reproducible results across the studies included. However, one important point is that a large proportion of women will test positive with HPV DNA. That is, the proportion of women living with HIV will test positive. And this is largely because the very high prevalence of HPV in women living with HIV, and not all of those infections will be linked to cervical precancer. Many of those infections may be transient and will clear over time. But because of the very high prevalence, this means that although the sensitivity of HPV DNA is high, the specificity to rule out CIN2 is slightly lower than what we would see in HIV uninfected women. And this is the reason why we have a triage, a recommendation for triage, a second test among HPV DNA positive women living with HIV. So these are the summary recommendations that were published in 2021. For women living with HIV on the right, we can see that a screen and triage approach is recommended where HPV DNA is the primary screen. This is similar to women in the general population. The only difference is that the triage step is recommended. The other differences for women living with HIV is that screening is started at an earlier age, at the age of 25. And this is based on evidence that cervical precancerous lesions can occur at an earlier age in women living with HIV compared to women without HIV. And because of their higher risk of cervical precancer and acquisition of HPV infection, screening is more frequent or recommended to be more frequent in women living with HIV. So that's every 3 to 5 years. When providing HPV DNA testing, either a clinician-collected or self-collected sample can be used, and this is quite important for settings where HIV prevalence is highest in sub-Saharan Africa. How are we doing on screening coverage then? So I presented this slide at a previous talk, so apologies that I'm repeating, but it's just to highlight again the disparity in access of screening in settings where HIV prevalence is highest. So we see that those areas in dark red are settings with the lowest reported coverage of screening, in that women reported ever having had a screening event in their lifetime. And in addition, in these same settings, VIA is most likely to be used where screening is available. On the other hand, although we don't have robust data on screening coverage for women living with HIV, we do know that screening coverage in women living with HIV is increasing in sub-Saharan Africa. And early evidence suggests that women living with HIV have potentially a twofold increased risk of ever having had a screening event in their life compared to women, their counterparts in HIV uninfected women in that setting. So in May last year, the WHO held a think tank meeting to understand some of these operational considerations for introducing and scaling up cervical cancer screening and treatment for women living with HIV. And it included individuals, program managers, members of ministries of health from settings where HIV prevalence was high. And this included 49 countries and 177 individuals. And what we heard over this 3-day meeting is some of the opportunities around introducing or scaling up cervical cancer screening and treatment for women living with HIV. And given the existing infrastructures in place to deliver HIV care, there's a real opportunity to harness that existing infrastructure through human resources, the established referral networks to link women to care following a screen positive test onwards to triage and treatment, the integration of lab testing where multi-disease platforms are used, and where HPV DNA is used as a screening test. This can be incorporated on some of the multiplex platforms already available for CD4 counter HIV viral load monitoring. There's also the opportunity to align the screening and treatment visits with the ART visit schedule. There's also innovations in ART delivery. For example, the differentiated service delivery and community-based models of care provide an opportunity to offer HPV self-collection to women in the community or their homes. But we heard that the role of patient navigators is really important in linking the screen-positive women to triage and treatment. And the established civil society experience through HIV care was discussed as being instrumental for educating women around cervical cancer screening, what it is, what it involves, the importance of linking to care, etc. Though we did hear about some challenges around financing and out-of-pocket payments. Often in some situations, screening may be free, but that additional triage step and treatment may require a cost to the woman. And monitoring and evaluation is important to understand the impact of screening and treatment programs on women living with HIV. And the comprehensive tracking and data systems for HIV provide that opportunity to integrate data on cervical cancer screening and treatment. However, the interoperability of the HIV and cancer monitoring systems is still a question that needs to be addressed. I just want to mention treatment of cervical precancer in women living with HIV. Current evidence base suggests, although it is limited, that women living with HIV have a higher probability of having recurrent lesions after treatment compared to HIV uninfected women. However, again, limited evidence suggests that the antiretroviral therapy at the timing of treatment is important in reducing that risk of recurrence over time, and especially where viral load is suppressed and CD4 count is high. It's really important that there's frequent follow-up of women living with HIV following treatment for cervical precancer, and some of the tests used for following women living with HIV following treatment are quite important in terms of detecting that recurrence. So finally, moving on to HPV vaccination among women living with HIV. As many of you know, we have several HPV vaccines available, some targeting 16 and 18, with one vaccine targeting up to 7 high-risk types that contribute up to 90% of all cervical cancers. So how useful would these vaccines be in women living with HIV? Well, very useful. I think that it's important to consider that despite the fact that the HPV prevalence is high in women living with HIV, and that women living with HIV have a broad, have a higher likelihood of being infected by multiple high-risk types, it's important to understand that the types that cause cervical cancer are the same in women living with HIV as in the general population. So HPV vaccines should have the same protective capacity in women living with HIV as in the general population. But there's another important point, that while women living with HIV have more multiple high-risk infections, a broad-spectrum vaccine could be beneficial given the high rates of the multiple infection among women living with HIV. And while we don't have robust evidence, the probability of women living with HIV being infected by all 7 high-risk types is very low. So there is some benefit to be afforded by these broad-spectrum vaccines. Equally important is the fact that even the 9-valent vaccine can protect against up to 90% of high-risk HPV infections linked to cervical cancer. There remains 10% of women who would not be protected from cervical cancer, and screening remains important in this population, and that remains the case for women in the general population as well. So some information then on immunogenicity and safety of HPV vaccines in women living with HIV. The very first studies, randomized controlled trials of HPV vaccines, were conducted in adult women living with HIV. So these were women who had been prior exposed to HPV infection. So therefore we would expect, because HPV vaccines are prophylactic, they cannot clear existing infections, that the efficacy may be slightly lower in this population. But what these studies did show is that the vaccine is safe and it's immunogenic in this population. So what they found was that the post-vaccination seroconversion rates were high and similar to women without HIV for 3 licensed vaccines. The antibody titers following vaccination were similar in women living with HIV as in HIV uninfected women up to 12 months post-vaccination. And I think we've got data now up to 24 months. And antibody titers were higher in women living with HIV who were taking ART, who had higher CD4 cell counts and undetectable plasma viral loads. However, there is some evidence to show that antibody titers do decline over time in women living with HIV. However, the antibody titers still remain above seropositivity cutoff. And it remains to say that we have no efficacy data against infection or disease endpoints yet in vaccinated women living with HIV, and no published data on immunogenicity or effectiveness of 1 or 2 dose schedules in people living with HIV, although this data hopefully will come in the near future. So the WHO recommendations on HPV vaccination schedules in people living with HIV are to prioritise the vaccination of HIV positive populations, including those older than the primary target age group, and with at least 2 doses 6 months apart, and ideally 3. I'm just going to finish by giving a very short summary of the HOPE study that's being conducted in South Africa currently. And this is a study that will evaluate the population level effectiveness of HPV vaccination in South Africa, a region with high HIV prevalence. And this study will use repeated cross-sectional surveys among young women aged 17 to 18 years. The first survey was conducted in 2019, and it will be repeated every 2 years. Another one done in 2021 and 2023. The National South African HPV vaccination programme has targeted girls aged 9 years in public schools with 2 doses of vaccines since 2014. So the aim of the analysis was to detect changes over time in HPV prevalence in the community in the period before HPV vaccination and the period after vaccination. And a secondary research question was to ask whether HIV infection status affects the protective effectiveness of HPV vaccines. So we don't have any published data on this yet, but I have just presented some of the very preliminary data that was presented at other at conferences. And what this study has shown is that there's some early evidence to show overall in the population, irrespective of HIV status, there is a decrease in HPV 16 and 18 prevalence. I should mention the HPV vaccine was the Cervarix, which protects against HPV 16 and 18. So there is evidence of a decrease in the prevalence of those types in the post-vaccine period compared to the pre-vaccine period. and that decreased from 23% to 12%. And promisingly, similar reduction was shown in those girls who reported being HIV positive. We see a decrease in the HPV 16-18 prevalence in that population from 33% to 21%. So hopefully this data will be published soon. And a key question that remains for people living with HIV is whether the duration of antibody response sustains over time, or whether there would be need for a booster. So just to summarize then, women living with HIV are at higher risk of high-risk HPV infection, cervical precancer and cancer compared to women without HIV. But there is a beneficial impact of ART, and importantly, HIV prevention and testing and early ART initiation is important to reduce that risk. Regular screening, cervical cancer screening is important, and there are opportunities for single visit to coincide with HIV visits. But novel technologies to give even better diagnostic tools are really the way forward in the future. People living with HIV, we now have evidence that they elicit a robust immune response following HPV vaccination, though we do need more data on efficacy and the immune response and efficacy of the reduced dose schedules as countries move to single dose schedule. Although people living with HIV have a high prevalence of vaccine types, the probability of being infected by all types is extremely low, and there is some protection to be afforded by a broad spectrum vaccine. However, cervical cancer screening will remain important for some time. And with that, I'll end. Thank you very much.
Thank you so much to both Helen and Samiya. And I think with that, we have time for a few questions. And so our first one is, what should advocates prioritize to address HPV and cervical cancer rates among key populations, including women living with HIV and sex workers?
Is that directed to anyone? Perhaps Dr.
No, I
Mahmoud?
think you can. So you can go first, and then we'll ask the same question to Samiya.
Yeah, I think screening and treatment services are now being rolled out in many settings where women are accessing HIV care, and I think it's really important that women take up the opportunity to be screened, but also are aware of the need to follow up on test results and undergo triage where that's needed. We have heard of the role of the community of women living with HIV and educating the community around the importance of screening. And I think that these are really promising initiatives on the part of the community. Thank you.
And so, Samiya, we asked you the same question on what should advocates prioritize to help address HPV and cervical cancer rates among sex workers?
Oh, okay. Can you hear me now?
Yes, we can
Okay.
hear you.
So the sex workers actually they are multi-exposed. So the government first built up the awareness to use the condoms and for regular screening for HPV vaccines. And already Helen mentioned that via screening is a very simple test. So come for the test and in 3 to 5 years interval. Actually, government promote for 5 years interval, but depending on the lesions, if they found any positive and they took the primary treatment by cryotherapy, they should follow up by every year for next 3 years, and then for 3 years for next 2 cycles, and then 5 years. So this is how they follow up their screening program, and we also emphasis to build up the awareness among them. So thank you.
Well, thank you both for those answers. I hope that today's webinar and our series really helps to bring awareness on cervical cancer and what this means for key populations, what this means globally. So I thank you both for your time today and for all of your expertise. And for everyone who's still on the line, the recording for this webinar will be available later this week, along with PDF copies of the slides. And with that, we are going to close our webinar series. And again, thank you so much to our speakers.
Thank you. Bye.